Yeah, well, thank you very much. Nice to be here. Well, I'm a PhD. I've got my PhD in genetics, master's degree in genetics from Illinois State University with Dr. Herman Brockman. And then I got a PhD in genetics from the University of Illinois with the late Bill Daniel. And then I did postdoctoral work at Yale University in the Department of Neurology, where I studied epilepsy and glycolipid biochemistry. So I was there for 9 years, also on the faculty at Yale University School of Medicine. And then I've been at Boston College since 1985, pursuing my research in epilepsy, glycobiology, and cancer. But we've now really shifted almost completely over to the cancer issue. So this is now my primary research emphasis is on the management and prevention of cancer. Yeah, well, I mean, when I was at Yale, I was interested. I thought maybe ketogenic diet, because it was the ketogenic diet got its first fame with the management of epilepsy in 1921. Wilder at Mayo Clinic in Rochester, Minnesota, was the first to test ketogenic diets on children. What he had studied was that water-only fasting could also manage seizures, but the problem is you can only do that for so long. And then he developed a diet that would replicate the biochemistry in the blood, so you could get a biochemical readout similar to water-only fasting, but you didn't have to starve yourself. So that was pretty powerful stuff. Dr. William Lennox had done some studies on this as well. He was a giant in the field of epilepsy research some years ago. And the mechanism by which a ketogenic diet would block epileptic seizures was never and still isn't fully understood. It works. It's something that really works well, but there's a lot of ideas about the mechanism by which it works. And when I was working on epilepsy, because that was the main focus at Yale University's Department of Neurology, we're one of the leading schools in the world on epilepsy. Mechanisms of epilepsy, and what I began to realize in studying this was that blood glucose played a very important role. And then later, when we started to do research on ketogenic diets, we were able to show that the calorie restriction, which is like water-only fasting, or ketogenic diets were equally effective in blocking seizures. And then we were able to relate seizure protection directly to the levels of glucose in the blood. And this is what we were seeing, my physician colleagues were seeing in patients. You can have a child managed long term for many months without a breakthrough seizure. And then, a drink of juice, a candy bar, a muffin, or whatever would spike the glucose. And within a few minutes, the child would explode into a seizure. So whatever was involved, it was the maintenance of low steady glucose level in the blood seemed to be linked to protection. Now, elevation of ketones, of course, a lot of people were interested in, what role do ketones play in managing epileptic seizures. I haven't yet found any tumor that has normal mitochondria. So I published a big paper on this in iScience. I went through all of the major cancers. I had to go back and dig up all these electron microscopic pathology reports from the 60s and the 70s and sometimes even earlier and look at the mitochondria under the electron microscope. Now, I just had to go back to the library and get the journal articles and then look at what those guys were showing. And the mitochondria are empty. They have breakdown of cristae. And then they have a lot of lipid droplets appearing in the cytoplasm. So I just published a recent paper. It appears that if your mitochondria are defective, the mitochondria cannot use fatty acids. And what happens, the fatty acids accumulate in the cytoplasm as lipid droplets. So when you look under the microscope, electron microscopy in cancer mostly, you see mitochondria that are abnormal in number and structure, and all of these lipid droplets in the cytoplasm. They're stored in the cytoplasm because they can't be burned in the mitochondria. Mitochondria defective. It's very similar to that. Lipid droplets, because in fatty liver disease, the mitochondria are also not working well. So, but we see now there's different reasons for why the mitochondria are working, and that's interesting because we found that all provocative cancer agents, whether they're carcinogens, whether it's hypoxia, whether it's oncogenic viruses, radiation, intermittent chronic inflammation, all of those conditions chronically damage the ability of the mitochondria to use energy from oxygen, consequently leading to a shift to using energy without oxygen, which is fermentation. And then you say, oh, okay, what are the fuels that are driving this fermentation? And we interrogated all this stuff, and it's only glucose and glutamine that are the drivers of this fermentation energy without oxygen. So now you say, oh, if that's the case, to manage cancer effectively, all we have to do is take patients, reduce their blood sugar down real low, healthy low, and then you come in, transition the whole body off to fatty acids and ketones, which the normal cells can burn and we can be healthy, but the tumor cells can't. And then you come in with the glutamine targeting drug and knock them out. So it's not that complicated, right? What happens is the mitochondria control the destiny of our cells. The mitochondria control the destiny of our very existence on the planet. When the mitochondria in our bodies run out of energy, we die. Okay, and human beings, if you can make 100 like the late Jimmy Carter, we have this big ceremony for him today. 100 years old is a pretty old guy, right? But we don't have human beings living to be 150 years of age. You don't. I mean, the oldest person that ever lived was Madame Clement from France. I think she was 122. That was the longest any human being has ever survived on the planet. We have a lifespan. Elephants have a lifespan. Dogs and cats, all these animals have different lifespans, which is dictated in large part by the mitochondria of those organisms. Go ask your friends and go down to whatever oncology center you have down there. They never heard that glucose is a driver of dysregulated cancer cell growth. Glucose is fine. Eat Infamil. Oh, what, you killing me? You take poison. It's like, give me a break. We got 1,700 people a day, and they're suffering. It's not like, whoa, a heart attack is great, man. You have a heart attack, boom, you're dead. You don't have to worry about anything. Now, here's the thing. With metabolic therapy, we can still use many of the procedures that are being used in oncology clinics, but we would use them in a very, very different way, much lower dosages, much different timing, which constantly reduce the toxicity associated with all these things. And what we know is that, and we developed the glucose ketone index calculator to allow cancer patients to know what it does is it measures the ratio in millimolar. That's the same mass concentration in a volume. Ketones in millimolar and glucose in millimolar, and then you bring that down to a low number. So most people in our society today eating highly processed foods with high carbohydrate content have a very, very high GKI, which means that the glucose level in the blood is massively higher than the ketone level in the blood. You do water-only fasting, restricted ketogenic diets, just even vegan diets, carnivore diets, pescatarian diets, whatever you do, you eat tiny amounts of it. And then all of a sudden, the glucose ketone index comes down. And when you get in the zone of 2.0 or below in that ratio, which we published, again, it's in the literature, this tumor cells start to get hammered. They start to up and die. They slow down. The inflammation in the tumor microenvironment becomes much, much, much less. There's death signaling, killing tumor cells, inflammation, angiogenesis, the abnormal vascularization. This is, we use these terrible drugs on people like Avastin. Oh my God, what a terrible, terrible drug. It's called bevacizumab. They call it Avastin. It's supposed to target the blood vessels in the tumor. You can do that by bringing your glucose ketone index down. You can target the blood vessels. We already showed all this stuff. So it doesn't cost much money, right? Avastin is extremely expensive to do that, whereas you could do the same thing with getting a low GKI. Once the patient is in a low GKI, which could take 14 to 20 days, which is okay, and then the inflammation, the tumor cells start to die, everything starts to get down. It's much less angry in the microenvironment. Okay, then you come in with the parasite medications, and you come in with the glutamine targeting drug, and you start slaughtering these damn tumor cells. And just like you said, you could come in with a small dose of radiation, a little bit of chemo at the end, or a little bit of immunotherapy at the end. It's like the finishing touch, get rid of the surviving cells. You don't come in like a bull in a china shop and go after this tumor with things that aren't going after the energy source of the cells. So you're 100% correct. The whole process has to be reevaluated and done the correct way if you want to improve quality of life and overall survival. If you're interested in improving quality of life and overall survival, the system must change. And it should change fast, because we're 1,700 people a day are dying from this. Well, Dorian came to me. He wanted to patent the GKI from me. I can't patent. We couldn't patent it. So it turns out patent attorney, you don't patent a formula. I developed the formula. We here at Boston College developed the formula, but we couldn't make any money on it. It's crazy. So Dorian ran with it. He wanted to patent it from Boston College. And we went over to the patent office. Oh, no, you can't patent a formula. So he said, oh, can I use it? I said, yeah, be my guest, use it. Now he's making all the money on the Keto Mojo meters. But and everybody thinks I'm making money. No, I get all our research comes from philanthropy. All of our comes from private foundation and philanthropy. So we have a number of really good people that are interested in helping save the lives of thousands of people, knowing that we can do that. So they just want to be part of it. And then when we publish these papers, that's why if you look at my publications on Access, which anybody who has a computer can go on the web and look at them, you say, who the hell are all these people? In the acknowledgement section. Yeah, well, this is the problem, because the medical establishment itself has written the cancer standard of care in granite. It's not to be changed. A standard of care should always be flexible in adapting to the new information that comes along, but it's not. And I know a lot of good MDs, physicians that really want to do metabolic therapy, and they're prevented from doing this for fear of losing their license. It's not been sanctioned by the medical establishment. So you go to the hospitals, and so the question is, and we keep publishing in good quality science journals for our colleagues, scientific and MD colleagues, and they know what we're talking about, but they always say, oh, we got to do another experiment. You got to do it. But we know what enough to do to keep people alive. We should be doing that, and then perfecting it as we go forward. And I have to be. We don't want to tell people that are in hospice, oh, we have the solution to bring you out of hospice. When you're in hospice,
right,
the system has already run its course. We see a number of people that have stage 4 cancer. They're diagnosed with, but they feel pretty good. I didn't know I had such a big problem. Right. Those are the guys. You hit those guys up front with the metabolic therapy and bring that whole thing under control. And then when it's shrunken down, you could use a small dose of radiation or even a surgical procedure and get rid of it. There's a lot of ways we can manage stage 4 cancers if you get it up front with the metabolic therapy. The problem is if you start poisoning these poor people, surgically mutilating them, the cancer spreads through the damn body because you've created a wound that actually cultivates the growth of these damn tumor cells. So because they're macrophages, and macrophages get all fired up when you have inflammation in the body. So we're doing everything wrong. We're not doing it the right way. Now, I'm not saying we don't use radiation and surgery and chemo and immunotherapy, but we use it in a very different way at a different time, at a different dosage.
Yeah.
But let's bring the beast under control in a dormant state, and then come in and finish it off with some of these other things. We got everything backwards. We're coming after these tumors like a bull in a china. Get that out of you. Give you toxic poison, surgically mutilate you, and the next thing you know, the poor person is, oh, he survives for a while, and he's, oh, I'm battling it, came back. Oh, it came back. Oh, it came back. It shouldn't come back. When you hit it up front with metabolic therapy and then go after it like that, I'm not saying we can cure cancer. All I'm saying is we can give these people a lot more opportunity to live longer. If they are cured, there you go. That's great. But they still live on the planet longer than they would have if they did something different. That's our plan. The body is an incredible healing machine if you give it the opportunity to heal. Right now, we're, for cancer, you're poisoning people, radiating them, making the body weak. cancer cells will survive. And then you give them all the sugar and the glutamine they need. Geez, I expect 1,700 people a day dying from cancer. Not a mystery. We told the neuro-oncologist that the worst thing you can do for a brain cancer patient is irradiate them, especially for glioblastoma, because what it does is it frees up massive amounts of glucose and glutamine in the tumor microenvironment. And then they give high dose steroids like dexamethasone to the brain cancer patient to reduce the inflammation, but that makes their sugar go through the roof. So we went through the mechanism and showed them why these GBM patients are all dying over a very, as a matter of fact, we published a paper showing that really haven't been very much advanced from 1926. So we really have, in 1926, death from glioblastoma was 8 to 14 months. In 2024, it's 8 to 17 months. We have made no advance in glioblastoma in almost 100 years. Absurd. It's absurd. Those people should have their head examined. The damn tumor cells can't live without glucose and glutamine. How is the vaccine going to target the glucose and glutamine? If the vaccine does a good job in taking away glucose and glutamine, it might be successful. But a vaccine can also cause more inflammation, driving in more glucose and glutamine to the microenvironment. I don't know what's wrong with people. As everything that I've just told you today, I might as well be speaking in some foreign language to think that I'm going to take a vaccine and I'm going to get the kind of therapeutic benefit that you should be. And they're very limited in how they get energy. They can't get anything from glucose and only that. So pull the plug on those fuels and you'll kill the tumor cells. And yet you go in for a vaccine. I'm going to radiate you. I'm going to do this. I said, what the hell, man? Don't you read the scientific literature? You should understand what's going on. Yeah, a lot of it is overlapping. You have to look at all these physiological markers and you begin to see commonalities in the way these things work. So, I mean, I know. And then when you say low fat diet, usually low fat means high carbs. We've seen, anything that can lower the glucose ketone index. You can do it as a vegetarian, a Mediterranean, a pescatarian, a carnivore. So it's whatever that person wants to do. We seem to find it work better with carnivore. And people, meat's bad for you. Well, if you eat crap meat that's all artificially produced and full of all this other stuff, then maybe it isn't the best thing. Our ancestors weren't eating highly processed, hormonally driven cows and elephants that they ate. they were eating what? They were eating organic animals, right? So, but yeah, the whole thing has to be reevaluated in light of biological evolution. Nothing makes sense except in the light of evolution. If people don't understand that, then they are susceptible to quackery. And we understand that real well. And when you understand that, then you can design things that really work and has a solid scientific platform. We're going to go through all the major cancers to show that they're all similar in their ability to get energy from glucose and glutamine. And perfecting dosage timing and scheduling so we can translate it immediately over to the clinics. So we're again perfecting dosage timing and scheduling. Also looking more carefully at the two pathways that are driving the metabolic, we call it substrate level phosphorylation, which is energy without oxygen. We're looking at the mechanisms by which we can improve that. Testing different tumors with different drugs and diets for sure, and trying to perfect this whole thing to make it as seamless as possible so that it can be immediately translated over into the clinics and then write case reports in human beings, more preclinical studies, linking preclinical studies with outcome in clinics. It's a work in progress. Eventually, the weight of the evidence is going to be so overwhelming. And then they're going to say, oh, this was obvious all the time. No, it wasn't. So you guys didn't know anything about glutamine fermentation. We showed that. We're the one who resurrected Otto Warburg, where he made mistakes, where he was correct, and where he was not correct. Just building it, you have to do. That's the way science works. And there's a lot of resistance to things that are disruptive technologies, changing the status quo. People are very comfortable and happy in what they're doing, except the cancer patients. So we're going to change. All that'll change. The bottom line is we got all those dead people coming in. I mean, that tells you whether you know what's going on or not. If you have 1,700 people a day dying at 70 an hour, there's something wrong here. You can't tell me that we're doing great work on cancer when we got 70 people dying per hour in the United States from cancer. Something wrong. There's no progress. No significant progress in dropping the death rate. Yes, we have isolated success stories, but the majority of people aren't benefiting from that. And that has to be recognized because we can drop that death rate significantly if metabolic therapy moves into this space.